Hello, everyone, and thank you for joining us today for this webinar. Just a couple things before we get started. You can use your chat function throughout the webinar to send in your questions, and we'll try to get to those at the end. And for the attendees that are here in the U.S., your certificates will be available tomorrow by logging into your account. Leon, if you'd like to introduce our speaker, go right ahead.
Thanks very much, Kim. Welcome, everyone. Thank you for joining us today. As Kim mentioned, my name's Leon. I'm Head of Breastfeeding and Research at Medela. Well, for us, the situation that we're all experiencing this year with COVID-19 pandemic has made a tremendous impact on the way we work and the way we function. And one of the things that we've noticed and that we've been concerned about over the course of this year is any negative impacts on breastfeeding and the use of human milk, even at the local and at the global level. And we've, like you, we've all seen different reports and different reports in the popular press and even in the scientific press. And it's been very difficult to get a hold of what the real data is. Even though global organisations like the United Nations and the WHO have all been very clear and consistent with their advice. So because of these discrepancies in the literature, what we've tried to do is organise a series of webinars that address this use of human milk and breastfeeding. And last week we were very fortunate to have the first of that series with Diane Spatz, and she provided a fantastic overview of the whole situation. And this week we're very fortunate to have Professor Lars Bode from the University of San Diego, or University of California in San Diego. Lars has done a tremendous amount of work in human milk and lactation over the years, and he's now the director of the Lars and Rosenquist Foundation Mother Infant Milk Center for Research Excellence, or as they prefer to call it, MOMI Core. And this is a real Centre of Excellence for research around human milk and lactation, and it really brings in a lot of varied disciplines and is able to mobilise very quickly, which is why we're very fortunate to have Lars give us the latest update on COVID-19 and its impacts in human milk and its impact on our day-to-day. And Lars, I'll let you take over from there.
Yeah, thank you very much, Kim and Leon, for inviting me to give this webinar, and thanks for everyone for coming on. Good morning here from San Diego, Southern California. I know it's a different time in your time zones, but it's really different times as we're facing this pandemic, and there's many unanswered questions around this disease and human milk. So I'm happy to start shedding some light into what we know about COVID-19 and human milk. Before I do that, let me go one step back, talk a little bit about what we do at MOMI Core, why we are studying human milk, and why we think human milk is so powerful before I then move into human milk in the context of COVID-19. The first part might sound like preaching to the choir here for many of you on the call, lactation consultants and nurses that know very well how important human milk and breastfeeding is. But there's others on the call as well that might not be that familiar with it. Plus, I think it's important to set the stage of the human milk first, and then discuss safety issues and potential benefits of breastfeeding in the context of COVID-19. So let's get started with first, what is MOMI Core? That's the Mother Milk Infant Center of Research Excellence endowed by the Lars and Rosenquist Foundation here in San Diego. And why are we actually so interested in human milk? So let's start with one of the sentences of the Lancet Breastfeeding series that many of you might have seen, and that says that the death of 820 children and 20,000 a year could be averted through universal breastfeeding, coming along with an economic savings of $300 billion. So that really sets the stage of how human milk is powerful and saves lives. It saves lives in the infant space, and diarrheal diseases is just one example. Every single day, we're still losing about 2,200 infants and children under the age of 5 dying from diarrhea. On the other hand, we know that children who are breastfed have a substantially lower risk of suffering and dying from infectious diarrhea, as well as respiratory infections. And as one of the topics at MOMI Core, we're trying to find out what is in human milk that makes it so powerful to save lives. But it's not just the immediate benefits for the breastfed infant. So not just during the time of exposure to breast milk, there is benefits for life. We know that breastfed infants have a lower overweight and obesity risk. We also know that infants that are breastfed have a lower risk to develop diabetes later in life. We also know that breastfed infants have a higher IQ and earning potential later in life. And what we don't know here is, how does this all work? What is in human milk and in the process of breastfeeding that makes it so powerful? On the other hand, it's not just good for the breastfed infant, it's also good for breastfeeding mothers. We know that women who breastfeed have a lower risk of diabetes. We know that women that breastfeed have a lower risk for cardiovascular disease, so heart attack, stroke. And we know that women that breastfeed and the longer they breastfeed have a lower risk of breast cancer and ovarian cancer. And once again, we can ask the question, what is in human milk that makes it so powerful to protect moms as well? And last but not least, we think that there is opportunities for people of all ages. So if you take a look at all the diseases that we're facing currently, cardiovascular disease, 18 million people die from cardiovascular disease every single year. Arthritis, diarrhea I mentioned already, infectious superbugs. It's expected that we lose about 10 million people every year by the year 2050 to infectious superbugs due to emerging antibiotic resistance crisis. 1 in 5 children will develop obesity, diabetes, inflammatory bowel disease, and breast cancer. So really, we have a world in crisis, and we had a world in crisis even before this pandemic hit. Now, for most of these diseases, we're looking for answers right here in the lab. We're developing new compounds, chemically synthesized, fit to target specific receptors. And unfortunately, many of these are not very tolerable, so they come with adverse side effects. And while this is the traditional way to find answers for these diseases, we think that we might have looked in the wrong places all along. So we're taking a different approach and look to human milk for new answers to some of those diseases. So not just in the prevention, breastfeeding and the prevention of these diseases later in life, but really taking a look at human milk. Can we identify specific molecules that then can be used as potential therapeutics for diseases later in life? I'll give you one example, and that is important to show how far we can push this if we talk about COVID-19 later on. So here I'll give you an example, and that's on rheumatoid arthritis. 1.3 million people in the US alone suffer from RA. We've been able over the last 3 to 4 years at MOMI Core to identify a specific component in human milk that reduces inflammation in tissue culture, reduces joint swelling in animal models of arthritis, can be synthesized at very low cost. So we're not saying that now our elderly with arthritis should drink human milk. No, we're thinking of specific components from human milk. And these components are safe for human consumption. They're made by humans for humans. And we're now moving into clinical trials with this particular project. So we really took it from tissue culture all the way to clinical studies. That's just one example. We're working also on cardiovascular disease, identified treatments and early life prevention. We're working on overweight and obesity, early life prevention and potential treatments, cognitive space, again, early life potential, but also later life treatment options. In the preterm space, we've looked specifically for necrotizing enterocolitis, colitis, and sepsis for prevention and treatment and point of care diagnostic. And in the diarrheal and infectious disease space, we've also found ways to treat those deadly bugs. So all this really means that we're not just looking to human milk for the benefit for the infant immediately. So we're looking at prevention, yes, but we're also looking at diagnostics. We're looking at human milk for new treatment options. And while all this is in the context of DOHAD, so developmental origins of health and disease, what happens early in life determines what happens to you later in life. So it's really a question of longevity. And while this is all embedded, of course, in health sciences, this is a question of public health, global public health. And it goes even a step further and has aspects of gender equity. It has aspects of racial equity. We know that, especially in the US, African Americans and the Latino population is more susceptible to some of those diseases, but also receives less support when it comes to breastfeeding. So this really has a society component to it and not just a health component. And last but not least, this might also have an environmental component. So, we think about the carbon footprint of developing and supplying infant formula instead of breastfeeding. So there's some research that's going on in that space as well. All of this was happening, and then we got hit by the coronavirus. So now the question is, well, what does the coronavirus have to do with the work that we're doing other than we're not being able to go to the lab as regular and frequently as we wanted to? Why do we look to human milk when we talk about coronavirus? So there's really a couple of questions here. One is, how about mother-to-child transmission? Is it safe to breastfeed? So is the virus present in human milk? If a mom is infected, does she transmit the virus with the milk to the breastfeeding infant? And can baby get infected through breastfeeding? That is crucially important if we want to provide data and evidence to guide and support parents in their breastfeeding decisions and also healthcare providers as they support the parents accordingly. But background of what we had seen so far, there were several published papers over the last couple of months that reported the occasional presence of SARS-CoV-2 viral RNA in breast milk from infected women. And if you want to read more about that, there's a review article that we published just recently in Maternal and Child Nutrition. Everything really is recently right now because this all started only in February or March over here in the US. So there's a few case reports beginning in China, then a few from Italy, and then a couple, one from Germany and a couple now from the US, that report that, yes, if we take a look at mom's milk, so moms that are infected, some of those milk samples contain viral RNA. And this is a great study that came out in Lancet a couple of weeks ago from Rüdiger Gross, the first author here in Ulm in Germany, very reputable lab in Ulm. And what they did is they had two different moms here. So mom one up on the top, and it shows you the timeline here in days. Up on the top, mom one was admitted to deliver her baby and delivered baby and tested positive shortly after she was admitted. So 4 days after admission, I think she was testing positive, was then separated from her baby. And while baby also tested positive after a while and had respiratory symptoms, milk was tested negative. At the same time, mom 2 comes to the hospital, gets admitted, and rooms in, so is exposed to mom 1, delivers 2 days later, and then also develops symptoms, and her milk tests positive. So you see the red bottles here, that is when mom's milk tests positive for viral RNA. That happens on day 10, 12, and 13, but then on 14, 15, mom's milk tests negative again. So there's a few samples that are testing positive and a few samples later that test negative again. Infant also develops or has a positive test, develops symptoms, and you see it develops symptoms for almost 2 weeks. So we don't really know if at this stage the infant is infected through the infected milk samples, or if the infant is infected because it was also rooming in with that one. It might have gotten exposed somehow different, not through human milk. So lots of questions on this, but it really raises a few questions here. So one is, if we talk about a positive milk sample, what does that actually mean? we tested by RT-PCR, right? And I'll tell you in a minute what limitations that has. So that's one thing. What does it actually mean if a sample tests positive? And most importantly, how frequent is this? So we have 2 moms here. Does that mean that in 50% of the cases, mom's milk will be contaminated with a virus? So that really gave us 2 questions here. One is, how frequent does viral RNA occur in breast milk? And most importantly, if we find viral RNA in breast milk, does that actually mean that we have an active virus that can replicate and cause disease? So to answer those 2 questions, we were very fortunate to team up with a group of scientists here in Southern California, both at UCSD as well as UCLA. And one thing I want to highlight here really is the outstanding resources of San Diego's Human Milk Research Biorepository called MOMI's Milk, which is led by Dr. Christina Chambers and managed by Carrie Bertrand. And this is a biorepository that has been going on for, let's say, 3 years. So we've been collecting milk samples from North America on an ongoing basis. And when the pandemic hit, we were able to capture some of those milk samples right away. So there was an ability to amend the IRB protocol, the ethics protocol, and directly go after those samples the moment we heard that there is a pandemic coming. So that really gave us a leg up in the race here to identify or to answer some of those questions. Now, none of us really are virologists, and we were very fortunate to reconnect with Dr. Grace Aldravandi's group at UCLA, just up the street, although it's not about 2 hours, depending on traffic. But we had worked with Grace already before a few years ago on human milk composition in the context of HIV transmission. And Grace, who's leading the division up in LA, has been working on coronavirus from day one almost, and they were set up to do all the different assays. So we could tap into that resource right away together with her colleagues, Nicole Tubin, Paul Krogstad, and Dave Contreras. So immediately we were up and running and were able to answer some of those questions. Immediately also, we were able to get some support for our research. So literally overnight, we sent an email to the Family Nelson Rosenquist Foundation at night before I went to bed. And the next morning, we had a commitment of emergency funding from the Family Nelson Rosenquist Foundation. Very thankful for that. We also got a very generous donation from philanthropists here in the community that helped support this work. Medila immediately jumped in and said, "We're going to help you. We provide breast pumps and supplies." And we also got help from the Mother's Milk Bank in Austin, which is part of the Human Milk Banking Association of North America. So it really shows you that it takes quite a lot of resources and expertise to address these questions right away. Research is not a sprint, it's usually a marathon, but we don't have time for a marathon here. This is an acute situation that needs answers immediately. Okay, so how do we do this? So let's take a look at the first question here. How frequent does viral RNA occur in breast milk? This is a figure from a manuscript that's currently under review. And what you see here is, again, a timeline on the x-axis. On the y-axis, you see different participants numbered from 1 to 18. So that's our different moms that provided the first set of milk samples. And the time point 0 here is when mom tested positive for the very first time for SARS-CoV-2. So that's her first time positive test. And everything is either before that, that's the negative time numbers, or after that positive test to the right. Now, you see different boxes on this graph. Each box represents a milk sample that we had available for analysis. There's 64 milk samples on this graph here. And you see there's white boxes and there is black boxes. The white boxes is milk samples that were collected when mom was asymptomatic. And the black boxes are collected from moms that were symptomatic. So this is when moms had symptoms, and you see from these 18 participants, number 18 all the way on the bottom had no symptoms at all. So it's a completely asymptomatic person that tested positive. And we had milk samples before the positive test and after the positive test. So that's down here, if you can see my point. We had also a few moms in this cohort that were severely sick. So we're not just talking about a few symptoms, a little bit of a cough here and there. There were moms in there that were intubated and even on ECMO. One mom did receive remdesivir. So we really covered the broad spectrum of symptoms from asymptomatic to tested all these samples by RT-qPCR. So that showed us that most of the samples were indeed negative, but one of the samples here in participant number 8, right at the onset of symptoms, tested positive by RT-PCR. So now you could say, well, 1 out of 18, that gives us a better idea of the frequency, or is it 1 out of 64, and what does this all really mean? So let's take a look a little bit deeper in what coronavirus actually is and what we're measuring there when we use RT-PCR. So let's take a little closer look at this virus. Here is a complete virus diagram on the left, but on the right we take this cut through to see what it actually entails. So you see there is this envelope, there is spike proteins, there is many other proteins around in this envelope, and in the middle, in the core, you have RNA and some proteins that are associated with that. And really what we measure with RT-PCR is fragments of that RNA. So depending on what kind of primers we design, we pick up small fragments of that RNA. So when we get a positive test by RT-qPCR, doesn't mean that we're seeing an entire intact virus. This could be a virus that's broken down and we just pick up those fragments by RT-PCR. So please keep that in mind. So the question now is, if we detect viral RNA, that RNA, does that actually represent an active virus that can replicate and cause disease? And that's very important, of course. If we find RNA fragments in human milk, we want to know, is that fragment representative of a virus that can now infect the infant, right? So let's go back here a little bit and see how a virus replicates in a human being. So we take here an animation that's really made for influenza, but it works pretty well for coronavirus as well. So what you see is you get the virus into the body, and then it gets into the epithelial cells here in the airway. It replicates in those cells and then comes out of the epithelial cells again. And now you have this massive amount of virus that is in the airways and can cause disease and can get spread as well. Right? So keep that in mind. What we need for a virus to replicate is an epithelial cell that can take up the virus and makes a lot of new viruses. So how do we mimic that in the lab? Right? We're not going to infect a bunch of humans and then see if breast milk does anything to them. We can't do that. So we use a tissue culture model instead. And we use, very common in biology, is these viral E6 cells. They come originally from a cell line that's from kidneys. And no, they're not green. This is specifically cells stained in a certain way. So all this work here is done by Paul Krogstad at the UCLA. And I could pretend that the photo that you're seeing up there is Paul. You wouldn't be able to tell anyway. In BSL-3 gear. This is not Paul. This is just a photo I found on the internet. But I think it shows the difficulty of working with this virus, working with human milk in these conditions. So you don't have a lot of space and you don't have a lot of leeway to move around and do all kinds of crazy assays, that you have to keep it fairly simple. Okay, so what we do here is in the cell model, we take the virus from a stock. So this is real SARS-CoV-2 virus, add it to our tissue. So you can really measure how much of that virus is now replicating. And you can then see, well, does it kill some of the cells? Are there some cytopathic effects? But you can also then go in and measure viral RNA fragments by RT-qPCR. So the more fragments you get, the more RNA is there and the more the virus replicated. Okay, so that worked very well. We established this assay, and now we needed to validate that for human milk as well. Here what we did is we took human milk that we already had collected from before. So this was way before the pandemic hit, meaning that it's very unlikely that this human milk had any of the virus in it already because it was from from 2017. Then we took our viral stock, add that to human milk at a known concentration and in different concentrations, we titrated this out, and then add the human milk to the cells, wait 4 days, and see if the virus is able to pop up and replicate. So we measure again the cytopathic effects, we measure the viral RNA afterwards, and as a result, we found that yes, SARS-CoV-2, when we add it to human milk ourselves, is indeed able to replicate. So in other words, if we take human milk samples that contain the virus because the milk is contaminated, we will be able to see that in this assay because the assay is sensitive and able to see replication if we use the matrix human milk. So that was very important for us to establish. Now we were ready to test our milk samples. So what we did now is back to the study that we did with RT-qPCR. All these milk samples here, including the one that tested positive by PCR, we now took, added to our tissue culture, waited 4 days, looked at cytopathic effects, measured the viral RNA, and as a result, and you see in the green dish here, there's no virus popping up, we found that none of the breast milk samples from our SARS-CoV-2 infected women contained replication-competent virus. And that includes the one sample that we tested positive by RT-qPCR. So in other words, the presence of viral RNA alone is not the same as presence of replication-competent virus. Just because we detect viral fragments or RNA fragments in human milk doesn't mean that there is an active virus in the milk that can replicate and cause disease in the infant. So while we were testing and validating our assays, we did one more experiment a few times actually. And what we did here is we took the virus, added it to our control milk from before 2017, and now instead of adding that immediately to the cells, we treated it by Holter pasteurization. We heated it up to 62.5 degrees for 30 minutes, cooled it down, and then added it to our cells. Right? And remember from before, if we do that, if we add virus to human milk without pasteurization, we get replication of the virus. So we tested that with pasteurization, and we found, and this is misleading, we actually found that there was no viral replication after Holter pasteurization. So in other words, even if breast milk was contaminated with the virus, doing pumping, doing handling, Holter pasteurization, which is commonly used by milk banks, inactivates the virus in contaminated breast milk. So even if we have a contamination, which is now not coming from the mom necessarily through the breast milk itself, but if mom pumps, handles, mom is positive, and the virus gets in the milk somehow differently, Holter pasteurization will take care of it. Okay, so let's summarize this part here. We found that the presence of SARS-CoV-2, spelling mistake there, RNA in breast milk of infected women is rare. We found it in 1 out of 18 women, but only in one sample. The presence of viral RNA is not the same as the presence of active virus. It's not the same as replication-competent virus. A fragment of a virus does not mean that the virus is intact and can cause disease. And very important, Holter pasteurization inactivates SARS-CoV-2 should breast milk ever get contaminated. So bottom line, transmission of SARS-CoV-2 from mother to infant through breast milk is unlikely based on the data that we have seen. Now that's just one part of the story, really. So yes, it is likely safe to breastfeed. Yes, the milk can still be contaminated through improper handling and so on and so forth, but Holter pasteurization will take care of it. But on the flip side, are there actually components in human milk that can stop the virus? So we know from many other diseases that if mom is exposed to a certain pathogen, bacteria, or viruses, mom will make antibodies. Those antibodies very often get transmitted with milk and protect the infant as well. So is it possible that that happens for coronavirus as well? We also know that there is many other components in human milk, and I'm only highlighting here oligosaccharides that we're particularly interested in, but also antimicrobial peptides and many other things that have antiviral activity. And identifying that will be, of course, important, again, to guide and support parents to not only say, yes, it's safe to breastfeed because the virus is unlikely to get transmitted, but it's also good to breastfeed because you have all those potentially beneficial components in human milk that will actually protect the infant from this virus and many other diseases. So it's important to get that message across, but coming back to what we've done in the early phases when I talked about arthritis and all these other components or diseases, is it possible that we can identify antiviral components in human milk that we then can synthesize and use as a new treatment against SARS-CoV-2 or in the treatment of COVID-19 symptoms that are now based on human milk components? So can we develop new antivirals to prevent or treat COVID-19 based on human milk? What does success look like in this space, in this very short-lived space? One is, of course, we want parents to be confident to breastfeed. We want healthcare providers making recommendations based on science, based on evidence, based on data, and not based on fear or dogma. Evidence is what matters. Science matters. And, of course, we would love to have a novel and safe antiviral component to help support stopping the spread of COVID-19. And last but not least, I think this is very important. This is not just a once-in-a-lifetime thing. It is very likely that we're going to face another pandemic. It's just a question of time. It's not a question of if, it's a question of when. So next time something like this happens, we need to be ready. We need to have the plans in the drawer already that we can pull out and say, these are the questions we need to answer in the human milk space. How do we treat human milk? Is it safe to breastfeed? Is it okay to that Holder pasteurization takes care of the virus? What does this all mean? We need to have these answers very quickly because it will save lives in the end, not just by preventing transmission, but also making sure that infants continue to get breastfeeding, get breastfed, and get all the benefits of human milk. So that really brings it back to the original statement I showed at the very beginning. We have all this data, and yes, we need to evaluate the risk of SARS-CoV-2 transmission through breastfeeding or breast milk, but we already know the risk associated with not breastfeeding. So we need to know very, very quickly whether a new virus is potentially transmitted, whether there is a risk for the infant to get infected through breast milk. And if that's not the case, then continue to breastfeed because we know it's so beneficial. And I bring it back to the opportunities for all ages, right? Is it possible that we can harness the power of human milk to discover new antiviral components to help stop the COVID-19 pandemic? Just like in the arthritis example I showed you before, can we identify individual components that can help either alleviate some of the symptoms like the cytokine storm or other things while we're waiting for a vaccine to come in? But let's not forget, and this is one of my last slides, let's not forget that we had a world in crisis even before this pandemic. All these diseases did not go away. We still have people dying from cardiovascular disease. People still suffer from arthritis, diarrhea. There will be an onslaught of infectious superbugs that we need to be able to handle. We all face still these problems here that we need to address, and we need to continue to address. And this is really what MOMI continues to do, and we call this the milk moonshot, looking to human milk for new answers in all these different diseases, either as prevention or as treatment. And I'll leave that and take questions. Thank you.
Thank you so much, Lars, for that information. That was very informative and very interesting to listen to and see. It'll be exciting to see what else comes out of your research that you're doing. We do have a little less than 30 minutes for questions. If you want to go ahead and send those in the chat function, Leon Matulis will be reading those off and giving those to Lars to answer. Right now, I don't see anything coming in.
We start off with one question. I think one of the listeners actually was a couple of moments ahead of Lars during the talk, and he got to the point of, are there treatments that can be generated from human milk? I think you outlined those opportunities, Lars. But in that regard, do you know of groups around the world or in the US who are actively pursuing and working in that direction at the moment? Is that something that's quite topical currently?
Yeah, so I know there is a few groups, including ours, that are interested in antibodies that are in human milk. Can we potentially use those? So first we need to identify, are the antibodies there? Are those antibodies actually neutralizing? So in other words, it's not just antibodies, but can we use those antibodies to actually neutralize the virus? So there's some work going on the antibody space in multiple different labs here in the US and I believe around the world. Like I said, we are specifically interested in oligosaccharides, and bringing it really back to the arthritis work, where we've seen that oligosaccharides can reduce chronic inflammation. This whole cytokine storm that we see as a symptom in COVID-19 patients is very similar to some of the work some of the effects that we see in chronic inflammatory diseases. So that's a certain direction that we're taking currently. I know there's others that look at antimicrobial peptides or proteins as well, and I'm not fully aware what else is going on.
Okay. No, that's good to know. Just moving on, there are some questions coming through now as well, and there's a couple of questions that are themed around the pasteurization data that you presented and the link into informal milk sharing at the community level. How do you reconcile those two in a COVID world? What are your recommendations in that regard as far as informal milk sharing?
Yeah, it's very tricky. So let's assume you have a mom that is asymptomatic and doesn't test positive but really carries the virus. Yeah, the chances that the virus comes now through human milk, as we've seen, might be low, but she might still spread the virus through other means and might contaminate the milk through other means there as well. And informal milk sharing, we usually don't have a pasteurization process in between there. So I would be very cautious with that. If you take milk from a mom that is not tested, I would recommend not doing that. I would go through the official routes there.
And with regards to the official routes, one quick question that's just arrived is, do the formal milk banks, you mentioned Austin and Humvana level milk banks, are they screening for mothers for SARS-CoV-2 or whether they've had it or not, or currently infected? Do you
know? I don't know that. We would have to ask the Humvana group there. I'm not sure what their current protocols are, whether they're testing or not.
Okay. Now, I think one very important part of your talk, Lars, was about the differences between an active virus and the techniques that are used to identify whether the virus is there, and that's based on the detection of certain RNA fragments. A couple of questions have come in just to sort of go over that part again and about, what does the RT-PCR, a positive association with that assay, mean versus the live virus in the milk? If you can just read through it a little bit.
Yeah. So just to go back to the previous questions, because I see there's a few answers coming in from other participants on the call, back to the Humvana guidelines. So apparently they are testing. Thank you for answering that for me, and I think it's all as well. So back to your question, Leon. So when we're testing for virus by RNA, by PCR, we're really only picking up certain fragments there, right? So So PCR works that you're designing primers that sit on specific parts of the RNA. You amplify that specific fragment, and then you measure that in the PCR. So you can imagine if you have a broken down virus that it's just shattered and might not be able to replicate, you would still pick up those fragments potentially, right? But that doesn't mean that those fragments can do any harm in sense of replicating in the host and then causing disease. So that's why for us it was very critical to say, well, multiple studies now have shown that there is RNA fragments by RT-PCR in some human milk samples, but what does that really mean? And by using this assay that we've used in the tissue culture, you could really say, well, if there is a live virus in there that can replicate, we will be able to pick that up. And not only that, if we spike human milk samples with active virus, we see that still works. So even in human milk as a matrix, we can still pick that. But to our positive surprise, that even if you have samples that test positive by RT-PCR, you'll not get active virus. And I think that's very important to differentiate, especially as there's more studies coming out that specifically look by PCR and might identify that there is fragments in there. It doesn't mean that is really causing or replication competent and able to cause disease. It's unfortunately very tricky to do these kind of tissue culture assays, as you need to dress up there and go in your BSL-free facility and work with the samples there. And not every facility, of course, has that available, and that makes it very tricky to test that way.
Yeah, that's great to go over it again. Thank you. Another couple of questions are sort of addressing the way that the virus can potentially, or the virus that you detect in the milk with your techniques, how it actually got there. And it would seem that the maybe droplet or contact, or even just the process of handling the milk could be as problematic, or maybe even more so. Do you have any thoughts in that regard?
Yeah, I absolutely agree. So it's a respiratory virus, right? So breathing, coughing, getting it on your hands, handling bottles and handling all kinds of other devices. I think the contamination risk is much higher than actually the transmission through the breastfeeding or through breast milk itself. I think it's more likely to get the virus into either the milk, into milk containers that way, or getting it into the baby in the end without milk, just by breathing, even if you wear a mask. There's no 100% guarantee. So I think the contamination risk there is bigger. But even then, it's not that we're seeing massive cases of very severe infections in infants, especially not in breastfed infants. I'm at least not aware that there is a lot of cases where we have infants infected with very severe symptoms. So I think that's a blessing in disguise here. So yes, it is important to know whether the virus comes through human milk, whether there's contamination risks outside of the breastfeeding process itself. But in the end, I think the symptoms, fortunately, in the newborn are not as severe as we see that in other age groups.
Yeah, agreed. Okay, some more questions associated with one question in particular with the technique. Maybe this is a quick one for you, Lars, in that the parts of the RNA that you're detecting, some of the SARS-CoV-2 reports that we've read talk about different mutations or different strains. Are your techniques suitable for all of them?
Depends a little bit on how you design the primers and where the mutation happens. So if you have a mutation that happens to be right where you design your primer, then you might not be able to pick that up. But usually most of the tests use more than one primer pair. So even if you have a mutation in one, you'll pick it up in the other. I don't know how rapidly this virus is mutating. So we'll see in the future how quickly we need to adapt our assays. But the tissue culture assay certainly is independent of that, right? Because we're measuring full replication And if we see that the cells get destroyed, even if we don't look at the RT-PCR afterwards, we look at cytopathic effects, you'll still see that even if it's a mutated virus.
Okay, thank you. How about questions? The pasteurization and the donor milk seem to be extremely topical with the people listening in today. And in particular, a question related to those parts of the world that perhaps don't pasteurize donor milk and do provide raw milk. Is there a recommendation, or do you think there's a recommendation there for screening of donors for SARS-CoV-2, whether they're infected or not?
Yes, I think so. I mean, if the response is here that even Humbrana, where we do the pasteurization process, is screening before, I would certainly recommend that for donations when the milk doesn't get treated afterwards. Absolutely.
Mm-hmm. And whilst the pasteurization process that we know, Holder pasteurization, and that you've shown and others have shown is very effective at inactivating SARS-CoV-2, what can you tell us about the Holder pasteurization process and its how friendly it is to the other components in human milk, particularly the antibodies and/or antivirals, the oligosaccharides that you're targeting as well? How does it affect those?
Yeah, I think that's a question that many people have been asking over the last years, really, not decades. How does pasteurization affect all the other milk components? And yes, there is some data that shows that some of the milk components get reduced in activity or get destroyed. Specifically for the oligosaccharides, we know that they do not get affected by pasteurization. They're very resistant to many other treatments as well. And then there's other components of human milk that are a little bit more fragile and not as resistant to pasteurization. So yes, certainly a trade-off between not having pathogens in milk and losing some of the bioactive activity. So certainly true.
Mm-hmm. Okay, I think we've managed to get through all of the questions that have come that have been dropped into the chat. If there's none others that appear right at the last minute, I think we can wrap up here, Lars. I think it's been a fantastic session. I think you've really been able to cut through a lot of the I will say misinformation that's been floating around out there and really provide a very precise view of how SARS-CoV-2 is interacting in human milk and what to do about it. I think picking up on one of the things you mentioned earlier, I actually think we're sort of sprinting a marathon at the moment in this regard, and you're right, there is a lot more work that needs to be done in this area, and it's fantastic that groups like yours and the networks that you develop are really leading the way in this regard. So from my side, thank you very much. Thank you everyone for listening. Lars, any last comments from your side? And you get to have the last word.
Well, thank you for inviting me again and giving me the opportunity to present our work here. It's very important to communicate this to the outside world and not just to the few scientists that work on this. I hope it became clear that it's not that easy sometimes to give you an answer, the correct answer right away. I think it's very important for every scientist really to be careful in how they communicate their scientific results and mention the caveats that come with it. And if we have to change our recommendations based on new science that comes in, people need to understand that science is a very fluid, research is a very fluid process, and things can change. So on a global scale, sometimes people will tell you masks are not effective, and then new data comes in and shows, oh, maybe masks are very effective, so we should all wear some. So it's the same here too. Research is changing based on new evidence that's coming in, and I hope that is clear and that scientists still have the reputation or keep their reputation even if recommendations have to change based on new data. I think that's very important to bring across. So thank you very much for the support that we've received from Medela over over the years, really, and certainly in this critical phase. Thank you very much.
Thank you, Lars,
Fantastic.
for presenting today. I just wanted to quickly say to everyone, the registration is available now for our July 2nd webinar. You can register and find out more information on our up-and-coming webinars by visiting medillaeducation.com. And if you're outside of the U.S. and you're interested in registering for the next webinar on July 2nd, feel free to email education@medilla.com for information. Thank you, everyone, and have a great day.